So here in Canada, exacerbations of COPD, the main reason patients come to hospital here in Canada. Fourth leading cause of death. Scary figures out of Ontario, that 1 in 4 people over the age of 35, and there are a few in this audience over the age of 35, will be diagnosed with COPD. And in Ontario, 12% of the population have had that diagnosis made, and they occupy 24% of available acute facility beds. It's really scary stuff. And it costs an estimate from some years ago, 750 million Canadian dollars to you, the taxpayers, to pay for the costs of these hospital admissions. Now, patients with advanced COPD, which is where I've been going, will tell you, and we have interviewed them, and they tell us that often their breathlessness or dyspnea is no longer responding to the type of conventional treatments and inhalers with which they're provided. So they have this thing called refractory dyspnea. But when we asked them what's most important to sort of straighten things out, they said, well, for heaven's sake, try and get on top of this symptom that I suffer from. So that's key for them. And they also want a plan of care after they leave hospital. And I didn't know back in 2000, when this data came out, that the Brits had done some work very nicely showing that living with COPD is quite often equal to or worse than living with non-small cell lung cancer. But the support has always traditionally been towards lung cancer and oncology, and we've only much more recently come to realize that we need to put support and palliation, effective palliation in place for patients with COPD. And we don't do it very well here in Canada. I mean, I think Jean's team probably is doing better than many. I think there's a C grade there, Jean, if I got the geography right. But this is from some years ago. But none of us have very much to be proud about here. And in the East, it's pretty dire. You know, there are F grades for Newfoundland, PEI, and New Brunswick. And so we have to improve on this. So a few years ago, I led a part of a study that went across Canada, and we were interested in understanding from patients with chronic illness what to them, and these are all patients admitted to hospitals, what to them constituted the most important elements of quality end-of-life care. And there are 118 patients with COPD in the study, and you can see there that they said not being kept on a ventilator, with no hope of meaningful recovery, relief of physical symptoms, and those two are pretty difficult concepts to deal with. But what's very simple, coming in at number 3 in the ranking, was an adequate plan of care after leaving hospital. At the same time, we asked the caregivers that we could of the index patients, and similarly asked the family members what's most important to you, and asked both of them, and how well is this being provided? You told us that this is important. How well is this being provided where you know, in your current situation? And we figured out from this another ranking that the things that we needed, the top 3 things that we needed to fix in healthcare for patients with COPD were as you can see them. And coming out on both sides, 2 and 3, adequate plan of healthcare services available to look after me or you at home after discharge. We had along the way I was leading some studies some years ago, and my team was out in rural Nova Scotia and rural New Brunswick interviewing families about what it's like to live with patients who have COPD. And this was real wake-up stuff. And so it's all about loss. And so they're no longer, the wife is no longer living with the husband she married and vice versa. There's this depression, there's relationships falling apart, there's all this guilt about smoking, depression, all these things. There's nothing positive on there at all. And this is the perspective from the family member, let alone the patient. And this was, in a sense, a bit of an epiphany moment. And if you're going to change healthcare, everyone needs to get off the treadmill. And so the epiphany moment for me was with my respiratory therapist who helped me set up Inspired, as she was then my research coordinator, interviewing the patients and the families in the rural setting. I'm not sure how much more distress I can listen to or papers we write before I know we're going to do something meaningful about all this. And this, you know, this was what drove us to get the pen out and the back of the envelope and then decide what it is we needed to fix. And that's in the setting of this concept of what does the road to acute care look like? You heard this morning about all these multiple emergency room visits. So for patients with COPD, it starts bottom left. As you look at it, poor knowledge of disease. That's absolutely true. Many of them don't know what COPD stands for. Nobody's actually gone through that stuff with them. They have little or no support in their local communities. They deny what's going on when their breathing's getting worse and their phlegm, their sputum changes color, and so they eventually show up in the emergency room much worse than they needed to have been if some of us had been able to intervene a little earlier in the trajectory. And that sets them up, this denial, and the worst physiological situation for a longer hospital stay, at the end of which there is a discharge plan. And a classic discharge plan of my medical teaching unit in Halifax is a discharge plan to get that patient discharged, because there are others waiting to occupy the bed. It's not a plan to keep that patient out of the hospital. And they're quite often not followed up, so they fall off the radar screen. So INSPIRED is an acronym. It stands for Implementing a Novel and Supportive Program of Individualized Care for Patients and Families Living with Respiratory Disease. So that worked out quite nicely as an acronym. And it's about evidence-based intervention. So we took the sort of work that Jean has been doing and others. We figured out what are the best things that we could put into this program that would create something special. And so we do the home-based support. We get to patients for 72 hours or so after they are discharged from hospital and then start a process. We figure out what it is they'd like to hear about and what they need. So we don't do anything formulaic, and we don't provide them with information they don't want. We figure out how it's best going to work for both of us, and that's the individualized bit. We know that action plans are very good. Randomized controlled trials have told us this many times, and so the patients all have these that tells them when to initiate some treatment for the next time there's a bit of a flare-up. And for specific patients where there is real trouble with breathing that might happen on episodic occasions, severe panic, it really is disabling stuff. We write particular action plans to help them overcome this crippling dyspnea or dyspnea crisis. Advanced care planning has been a very major part of what we do. We did all these interviews in the qualitative research we had done previously, felt that the extent of the existential distress that we heard about mandated that we use some of our local spiritual care skills in Halifax as part of the program. And that's been a very key part of the program, and it's played out, as it happens, extremely well. So this is what it really looks like. The patient is identified in the hospital on the medical floor. We seek their consent after providing an information brochure that tells them about the program. We have been very keen to evaluate and evaluate and evaluate all the way along since the outset of this. Essentially, 4 home visits, 2 by respiratory educators. On our team, it's part-time respiratory therapists, 2 visits that follow from spiritual care that address the other issues that are important to discuss. So some post-evaluation measures, and in our early stages, a follow-up phone call every month for about 3 months. Critical element of the program was the advanced care planning because it builds on the trust, and we can take patients on the journey towards some decision making about the difficult things that are going to happen at some point with COPD. And Jean talked about goals, and I think we're all doing this approach now, working towards relevant goals. And the patients have told us they want these discussions because it breaks the silence that has always been there and all their previous hospital admissions that nobody goes there for them. So we did both qualitative and quantitative evaluations. Qualitatively, patients told us they felt more confident managing their symptoms, less anxious, and they're willing to discuss goals of care, including end-of-life care. We did some quantitative studies, most of which did not play out statistically significantly in the early stages, although one did, and I'll come back to that. But more importantly is hearing what some of the patients and the caregivers have told us, and remembering that the second I in INSPIRED is individualized. So the lady you saw with the poodle said, I used to feel so alone with my illness. Now people check on me and I know there's someone I can call if I'm having a problem. I'd feel so isolated, frustrated, and apprehensive without this support. And we had this on a card recently from a caregiver about her mother. There were times when panic was setting in. It was a tremendous relief to know that I wasn't alone and that there was somebody who cared that I could turn to. You handled Mum with such dignity and respect that I can never thank you enough. So it's very nice getting these kinds of cards, and we get many. Why did it help? They told us, and the top 5 reasons we ranked again, the action plan and having antibiotics and corticosteroids or prednisone available in the home. They don't have to wait to get an appointment with a family physician that may take them in Halifax 2 weeks. I don't know what it's like here on the island, but the spread is enormous, and many people do not have family practitioners, so having available medication is a very good start. Accessible education and resources, little handheld fan that costs less than $5 that if they hold and blow cold air on the face can actually help relieve their breathlessness. Outcomes that are relevant, someone to call, as Jean alluded to, and feeling cared for, which is not a sentiment that is often expressed traditionally about how patients with COPD feel about their physicians or nurses or anyone else in their care. So briefly, and this data will be published this weekend, as it happens, in Clinical Investigative Medicine. Here I'm taking you through a recent analysis. Just at the top, we have about getting towards 300 patients currently enrolled on the program. The 131 at the bottom represent 131 who, for the purposes of this analysis, had completed all elements of the program, had survived for at least 6 months after the program. And that's how we reached the 131 for this particular analysis there. So it's a relatively homogeneous group. And if we look at their behavior, as it were, facility usage in the 6 months prior to their index admission, the 131 patients had 282 emergency visits, 154 hospital admissions, and occupied 1,573 days in a hospital bed. Bearing in mind, hospital bed cost is estimated about $1,000 a day. 6 months later, after our involvement, we're down by about 60% on all of those important markers. And if you do a little bit of maths and you just look at 997 less bed days occupied that might otherwise have been occupied, because you would expect their facility use to increase, because that's the nature of the disease, not to decrease, we're averting nearly $1 million of healthcare costs, which is at least 2 to 3 times how much it cost me to run the program, which started off in the early stages as a bit of me on the medical side, spiritual care practitioner, and a respiratory therapist, 3 of us. One statistically significant measure was the care transition measure. It's a measure of self-efficacy and self-confidence that a patient has in they understand their disease and they know what to do with their medications. That shot up relatively highly statistically significantly. And if that's in 27 patients, probably there's something fairly significant going on here. And that makes sense in terms of less facility usage, because if they feel confident and they're managing well at home, they wouldn't be showing up again as often as they did before. And very briefly, I apologize, these are a bit small, these numbers, but this is where we looked at 93 from the 131, where we had a year before behavior and a year after facility usage. And we took 2 6-month blocks before the index admission. And you can see that for all of the things that we measured, emergency room, admissions, length of stay, there's an increasing frequency of usage prior to the index admission. And that turns down really quite dramatically in the first 6 months afterwards, and then starts creeping up again towards a year after. But we're looking, if we just do a simple analysis of 6 months, it's about 80%, and at a year, about 60% as they start coming back again. So this is looking fairly promising. We looked also at what happens to people who did not survive. And we have about 20% mortality on an annual basis because the patients are fairly severe that we get to. 20 deaths we looked at within the program versus 96 outside of the program, all related to COPD. So significantly shorter length of stay. The patient in the INSPIRED program was able to stay at home longer prior to the death if they in fact came in to die in hospital. But 6 didn't, which is, we thought, remarkable because it's very hard to orchestrate a respiratory death in the home because the caregivers are totally burnt out with what's already happened. And to ask them to manage the dying patient in the home at the same time is just too much. And yet that we were able to do that because we have now part-time palliative care on our team, and my spiritual care guru would be able to go out and help with some of the other issues of distress. And we also had a much higher proportion of available personal directives to the clinical teams in the hospital, so people knew what to do. So, you've heard a bit about relationships, because this is what I think we've created here, relationships with patients that hadn't to this point existed. And clever people in Alaska have taken relationships and spelt it out this way. And I was very impressed when I saw this. And I won't go through all these at all, but you get the idea. I mean, A for access is optimized. We go to the patient's home. We don't ask them to come to the hospital. And we do the one-on-one teaching in the home, which is where we differ from Jean, but it's different. It's just a different approach that we adopted here, because we can't do what Jean does in the pulmonary rehab setting as well. So this is where we are. Last couple of slides. So we're right over here on the right-hand side. And I think two key things. We were designated a leading practice by Accreditation Canada earlier this year, which is rather nice. And the really exciting staff, and Maureen O'Neill and Stephen Samis are here from the Canadian Foundation. We have a collaboration between the Foundation and Boehringer Ingelheim that is funding 19 teams across Canada to implement, with a $50,000 startup fund, a similar kind of program in each of the provinces. I think the next one is a map. It is. So you can see Quebec has 4 teams. And we did a CIHR type assessment. Stephen was there of the various applications we had and settled finally on 19. And there's an announcement about this in Toronto on Monday evening, and there'll be a certain amount of press coverage for this kind of thing. So thank you, Maureen and Stephen. I have to say that publicly. That's it. We're done.